Hi, this is Sherry Shabowski, and I'll be talking to you today about pediatric intubation. Now, when are you going to need this skill? Well, there are certain indications that you have to consider. First is failure to oxygenate. That's after you've tried to give the child oxygen, but still they remain hypoxic. Or failure to ventilate, which means the child is not breathing effectively and the CO2 is climbing. Or for suctioning, things like meconium or secretions in the airway. Or in the case of ACLS, you can give medications through the endotracheal tube. Before you consider doing this, plan ahead. Get everything ready. Because if you're not ready, you'll need the exact thing you forgot. So plan ahead. Have a list. Make sure you have a bag valve mask. It should be the size appropriate for the child. You don't want to be ventilating the child's eyeballs with oxygen. Have an oxygen source. Have your bag valve mask plugged into that source. Have pulse oximetry and end tidal CO2 so that you can monitor what's going on with the child during the intubation. Have a towel available for positioning. You need an optimal position for the airway to make it easy for yourself to actually intubate. Make sure your suction is on. I myself have kind of like a tick. I have to hear the suction before I start to intubate because that's a big miss. If you have a lot of vomiting or a lot of secretions and then you have to set up the suction at that time, that's going to be problematic. It's very important to have that ready long before you start. You might need medications to sedate the child. You'd like to have that available with extra dosing as needed, available at the bedside. You need a laryngoscope that you're comfortable with. There's a lot of possibilities. Airways can be difficult. You want to use the one that you are the most comfortable with because you want to have the optimal success. You need several endotracheal tubes in sizes that are matched on the Broslow tape. You need one smaller and one larger than what's recommended, just in case. And make sure you have the cuffed endotracheal tubes because they're less likely to be able to be tongued out by the baby. The balloon that's on there holds the endotracheal tube within the airway and makes it difficult for it to slip out. Make sure you have tape or some other securing device available. And then you might want to make sure that the respiratory therapist is there with the ventilator, unless you want to be bagging for an awfully long time. Breathing is definitely a problem, or you would not even be considering intubation. So make sure the first thing you do is open the airway. Sometimes just impingement on the airway when the child is not conscious will stop them from breathing, and just opening up that airway will make them breathe. And then intubation may or may not be necessary. Have a bag valve mask to ensure adequate oxygenation and ventilation. You want to pre-oxygenate before you decide to intubate, just so you have the optimum conditions so that things go well. And then when you need to, you'll also resuscitate before the intubation. Sometimes the resuscitation makes the intubation unnecessary, especially in the case of ACLS. Remember, in a small baby, the occiput is large. As you see in the picture on the left, the airway is kind of closed and the tongue is pressing on that airway, not in the most optimal position for breathing. When you put the towel between the child's shoulders and the occiput is a little lower and the chin is a little bit higher, then you have a wide open airway. This is better for the child to breathe. Additionally, it's easier for you to see the airway under these circumstances. So good and good. Then you'll use a cuffed endotracheal tube. You put it in with the balloon down and then blow the balloon up once the child is intubated. Again, this makes it less likely that the child's tongue can remove the tube from the airway. That balloon will hold the tube below the cords. This is a Broslow tape, and it should be used for all kinds of sick children that are needing to be intubated or resuscitated or needing a lot of medications and special equipment. This tells you the sizes that match the child's size. And this is super important in little children and babies because it varies quite a bit. Doses vary, sizes of equipment varies, and you need to know this. Tough to memorize every single one. So this Broslow tape really helps you out. You lay it next to the child and measure the child and find out where he lands on the Breslow tape, and then you have a great idea of dosing and sizes for everything you might need. Now you're going to consider intubating. When you intubate, you put the laryngoscope in, pull the tongue out of the way. The airway is going to be very anterior. It's going to be the highest point in your view. So that tongue is going to have to be out of the way. The vocal cords are located behind the epiglottis. Once you see the vocal cords that look like a pyramid, you're going to put the endotracheal tube through those vocal cords. If you don't see any structures, it's very likely that you're going for the goose. The esophagus, that is. Here's a picture using a straight blade for intubation. The tongue is moved out of the way. You see the vallecula. The large picture up in the right, is that of the vocal cords. Here you see those vocal cords open. Usually they're a little triangular, but they look very much like this. This is a perfect view of the entire vocal cords. You're going to put that endotracheal tube right through that black hole in the center. Looks like in this picture, curtains being drawn on a stage and opening up. You're going to put that endotracheal tube right in the center of the stage. During intubation, there's things we have to consider. If not paralyzed, the cords will be opening and closing with each breath. This can be a little strange. You are not going to be able to intubate or push through when the cords are closed. If you try, this can be very damaging. So what you want to do is wait. Wait until the child blows out all the air from an exhalation, and then as soon as the child starts to inspire, that's when the vocal cords are going to be open the most. Right at the initiation of the breath. That's when you're going to try to push the tube through that opening. Watch it go through. A lot of people make the mistake of thinking they're right next to the cords, and then they push forward and the tube either curls up or goes down into the esophagus because you did not get it through the cords. Try very hard to watch the endotracheal tube go through the cords. It's very helpful with positioning and not causing errors. Bag that endotracheal tube once it's in and the balloon is blown up. Watch for bilateral coordinated chest wall rise and fall. This is important because this gives you some sense that the endotracheal tube is in the right place. Now, children's stomachs can grow very large when the endotracheal tube is in the esophagus, and sometimes you hear the sounds of the ventilation on the chest wall that are emanating from the stomach. So be very careful to see the chest rise and fall. This helps you to know that the tube is in the actual lungs themselves. Now they're going to listen for breath sounds. Again, know that the breath sounds could actually be coming from the stomach. So it can be tricky because the chest and the stomach are very close together in tiny little babies. Also, if the tube is uncuffed, the child may be breathing around it. Even if it's in the esophagus, the child might still be breathing on his own if you have not stopped him from breathing. So it could be tricky here. You're going to also need end-tidal CO2 monitoring. That's going to help you keep track and make sure the endotracheal tube is in the right place and remains in the right place. There's also pulse oximetry and ultimately a chest x-ray. Now, a chest x-ray gives you some sense of where the tube is, especially if it were kinked or turned upwards, like in a U shape. But you can have an endotracheal tube in the esophagus, and on an AP film that's taken at the bedside, that could be very confusing because the esophagus lies directly under the trachea. So sometimes it can fool you. So be very careful and check your endotracheal tube placement in many different ways. While you're doing it, it can't take forever. Some people say hold your breath, and you'll know how long the baby can hold their breath if you're running out of air while you're intubating. And then you stop and beg until the patient is oxygenated and ventilated well again, and then start the process over and take another look. I don't know about holding your breath, because if you go down, that's not going to go well for the baby or anyone in the room, so maybe not hold your breath. But the baby is typically not breathing or not breathing effectively while you're doing this. So taking them off oxygen in order to get this done can be problematic if you take too long. Make sure that someone's watching your monitors, watching for bradycardia, hypoxia, hypercarbia. Any of those things would be considered a likelihood that the child is not oxygenating or ventilating well. In that case, you would stop what you were doing and bag the patient again, and then try the intubation again. Securing the tube is essential. Bag the child gently with the correct size bag until the ventilator is ready. Confirm pulse ox and end-tidal CO2 is appropriate, and then paste the child on the ventilator. You can secure the tube with tape or devices that are made specifically for holding the endotracheal tube in place. All right, it's in. Great job.